Hello, my name is Talk Kuestner from the King's College London, and today I would like to present you our work on deep learning-based super-resolution reconstruction for sub-millimeter 3D isotropic coronary MRA in less than a minute. Cardiovascular disease accounts for 45% of all deaths in Europe, amongst which 50% of all deaths are related to coronary artery disease. 3D whole heart coronary MRA has been presented to visualize the coronary arteries, but requires long acquisition times. Therefore, undersampled and accelerated CMRA acquisitions have been proposed using compressed sensing, acceleration, and reconstruction. However, also here you need to make a trade-off between achievable acceleration, residual aliasing, and the achievable scan time. For CMRA, it is essential to acquire sub-millimeter 3D spatial resolution to correctly visualize and characterize the coronary arteries. However, as a downside, this requires usually long acquisition times. In this work, we aim to extend on previously proposed approaches, and we aim to acquire a low resolution CMRA in an acquisition time of around 1 minute, and to utilize in the reconstruction a sub-millimeter high resolution reconstruction via a deep learning based super resolution approach. We acquire CMRA data with our previously proposed 3D isotropic whole heart CMRA acquisition, which is an ECG triggered BSFP acquisition with T2 prep and fat saturation pulses, and a 2D image navigator to allow for B2B translational respiratory motion correction. We use 3D Cartesian variable density Casper sampling to provide an incoherent undersampling, which allows in the reconstruction a retrospective binning of the respiratory motion with an efficient reconstruction from it. Respiratory motion is then resolved on a beat-to-beat basis, and after respiratory binning, we can estimate 3D motion fields allowing for 3D non-rigid motion correction, which is then performed in a motion correction and patch-based low-rank reconstruction to provide a motion-corrected 3D CMRA image. Following the motion-corrected reconstruction, we perform a 8x8-fold super-resolution upsampling from the low-resolution acquisition of resolution 4.8, 4.8 by 1.2 to the sub-millimeter resolution of 0.6. This is performed by an enhanced deep residual network for single image super resolution EDSR, which is trained in an adversarial fashion in a GAN architecture. And on the training side for that, we utilize high resolutional data of 0.6 millimeter isotropic resolution, which we retrospectively downsample by 12.5% phase and 3D phase encoding directions to provide us then with the training input. We train it in conjunction with a discriminator architecture, which gives us an adversarial loss together with a pre-trained VGG16 network to give us a perceptual loss, and together with MAE and SSIM losses to drive the overall training process. Overall, we get around 2.4 million parameters, which are trained by an ADAM optimizer. We acquired CMRA data in 50 patients with suspected CAD on a 1.5 T MRI with our proposed CMRA acquisition, yielding us a 3D isotropic whole heart coverage for a high resolutional acquisition of 0.9 millimeter, which got reconstructed to 0.6 millimeter, which was acquired in a scan time of around 7 minutes. As previously mentioned, we simulated a low resolutional input for training by a 12.5% phase and slice resolutional downsampling. We acquired a second cohort in 10 patients on the same machine with the same imaging conditions, where we acquired 2 acquisitions, a high resolutional 1.2 millimeter isotropic, which got reconstructed to 0.6 millimeter, acquired in the same scan time of around 7 minutes, and a prospectively downsampled acquisition with the resolution of 1.2, 4.8, 4.8, with an overall scan time of around 1 minute. For training, we took subjects of cohort A and a few further subjects in 5 cross-validation runs for retrospective analysis. And in cohort B, all the subjects which were prospectively downsampled were taken for testing. First, let's look at some result of the retrospective downsampling, meaning we had the high resolutional target, which got retrospectively downsampled to the low resolutional input. And here you see the coronal, some zoomed in version to the coronary arteries, and some coronary reformat of the low resolutional input, the high resolutional target, a B-cubic interpolation, the super resolution reconstruction to the 0.6 millimeter isotropic resolution. We see that we can nicely recover the high resolutional data from this low resolutional input, and also coronary arteries which get obstructed and lost from the low resolutional acquisition can be recovered again by the high resolutional upsampling, which cannot be recovered by just performing a B-cubic interpolation. The same observations also hold true for a second patient of this retrospective downsampling. We can also appreciate for different spatial locations the good depiction and recovery of the vessels for the proposed super resolution reconstruction. We also performed some quantitative analysis where we compared the low resolutional input, B-cubic interpolation and super resolution reconstruction to the high resolutional target for this retrospective downsampling. And in terms of NMAE, normalized mean squared error and structural similarity index, we found statistically significant improvement with overall high improvement of the quantitative scores. And the same observations also hold true if we move now to the prospectively downsampled cases, where you see here in one patient the low resolutional acquisition from which we can reconstruct a very nice high resolutional reconstruction of sub-millimeter resolution, which is in good agreement again with the high resolutional target and which could not be recovered by just performing a B-cubic interpolation. We also see good depiction of the coronary arteries in 2 further subjects, also in cases where fat saturation was impaired, going again from the low resolutional acquisition to the super resolutional reconstruction to a sub-millimeter resolution. Please note that the scan time for acquiring the low resolutional data was around 1 minute in comparison to the 7-minute acquisition for the high resolutional target. On a prospective cohort, we measured vessel sharpness and length in the coronary reformats for LAD, RCA, and RCA, and we found statistically significant improvement for all the parameters for the super resolutional reconstruction. Overall, I showed you our proposed approach of a super resolution CMRA, which enables sub-millimeter reconstruction of a CMRA acquisition of around 1 minute. On the acquisition side, we utilized our previously proposed approach with a 3D Cartesian variable density Casper sampling, acquiring a low resolutional data in around 1 minute, which gets then reconstructed by a motion compensated post reconstruction, followed by our proposed deep learning based super resolution, which performs the 8x8 fold upsampling to the high resolutional target in around 3 seconds. We evaluated this proposed approach in the retrospective and prospectively downsampled cases, and we found improved edge sharpness and vessel delineation and comparable image quality to of the super resolution to the high resolutional target. With this, I would like to thank you very much for your attention, and thanks to all the colleagues who contributed to this work.